37-year-old female, incidental basilar tip aneurysm after investigation for dizziness. Neuroexamination, normal. This is her MRI. You can see here already in the coronal cut, this basilar bifurcation aneurysm over here. And this is sagittal cut. Apparently it is the basilar bifurcation aneurysm is pointing upwards. Here's the axial cut showing the aneurysm. So this is her MRA showing, this is AP view, frontal view, showing the basilar bifurcation aneurysm. And this is the oblique view, posterior lateral view of the aneurysm. And this is the lateral view of her CTA. I wanted to see the relationship between the neck, the level of the neck of the aneurysm to the dorsal sella posterior clinoid process. In this CTA, the neck apparently it's a little bit lower. You know, ideally the neck will be at the same level of the dorsal sella. That would be ideal. So I would not have to remove the dorsal sella or posterior clinoid process. But in this case, the neck is just a little bit, maybe a little bit low. So maybe in the surgery, I have to remove the posterior clinoid process. With the reconstruction, 3D reconstruction of or MRA or CTA, it is wonderful for you to place the patient and also the aneurysm in the what you expect intraoperatively. So this is what I'm expecting intraoperatively. This is carotid artery, basilar artery, the left posterior cerebral artery, and the right PCA. And this is the aneurysm. So this is the way I'm expecting to see in the surgery. So she underwent right Teriona approach. So this is the exposure after the dura opening. This is the right frontal lobe. This is the right temporal lobe. And the Sylvian fissure has already been opened. So let's go to the video. Placing a spatula, MCA, and trying to dissect. Here's the MCA, cutting the arachnoid. This is third nerve, opening the Liliequist membrane. Continue to open the Liliequist membrane. Third nerve, PCA, and now I can see the basilar artery over here. So this is PCOM. This is MCA. So I try to preserve the draining vein, you know, this vein, but it's impossible. I have to cut it. Otherwise, it's not possible for me to retract the frontal lobe. So coagulating and cutting the vein that comes from the frontal orbital region. Now I am dissecting the arachnoid over the third nerve. We know that there is an oculomotor cistern. So there is a certain length. The third nerve will carry its own cistern until it enters the roof of the cavernous sinus. So I have placed a stitch over here, and then I'm opening the dura until I see the third nerve entering the cavernous sinus. Now see this is a posterior clinoid process medial to the third nerve. This is PCA, and this is PCOM. PCOM is right in my way, between me and the aneurysm. So I have to coagulate the PCOM at the posterior, closer to the P1 or P2A, because you see there are branches, anterior thalamo perforating branches coming from. You have to preserve, so that's why you have to coagulate and cut very close to the PCA, not close to the carotid artery. Now opening the arachnoid lateral to the third nerve. You can see the superior cerebellar artery over here. So carotid artery, MCA, A1, right optic nerve, aneurysm right here. So I was checking and looking for the posterior thalamo perforating arteries. I have to preserve those. This is a basilar artery. This is a posterior thalamo perforating artery. I need to expose the basilar artery for proximal control. So this is the aneurysm. This is the exposure through a terional approach. I was experimenting. I was trying to put the temporary clip. Not enough room for this. So I have to open the dura over the posterior clinoid process. And once you do that, you can open the cavernous sinus. So fibrin glue can help you to stop the bleeding from the cavernous sinus. Then I can use either Kereson punch, or you can use the diamond bit drill to remove the posterior clinoid process. I used both. So this is a drill. Just make it flat, so I can. This is a fibrin glue. I have to remove the excessive. So now I have a little bit more room. This is between the posterior cerebral artery and then superior cerebellar, and I'm just testing, making it see how large should be the clip to include the whole neck of the aneurysm. Now I have room to place a temporary clip after drilling, removing part of the posterior clinoid process. Now the basilar artery has been clipped. Now I have the right length of the clip. So sparing the thalamo perforating artery over here. Sparing also on the right side, thalamo perforating artery. After clipping the aneurysm, I quickly removed the temporary clip, and I was checking mainly the posterior thalamo perforating artery on both sides. They all have been spared. Now additional clip, just to be sure, because the flow of the basilar arteries is usually very strong. So I was afraid, just using one clip is not enough. This is ICG, just confirm that the aneurysm has been successfully clipped. Now it's becoming more and more popular here, even in Brazil. This is really a very helpful technique to see if the aneurysm has been clipped, and even the posterior thalamo perforating artery has been saved, preserved. It's really very useful, ICG. She presented complete right third nerve palsy after the surgery, with complete recovery after 10 weeks.